Okay, welcome back everyone. We're going to have one more hour of formal presentations for today, and during that hour we'll be hearing from some more fellow NIDLR grantees in the knowledge translation portfolio. Becky Matter and Dr. Mark Harnitz are with us. They're from the University of Washington, which houses the ADA KT Center. So this is the KT Center that serves the network of 10 regional centers that educate the public about the Americans with Disabilities Act, hence the name KT-ADA. And their talk is called Practical KT, Ensuring Relevance and Use. And we're going to hear first from Mark.
Okay, thank you. So thanks for having us. Becky and I are excited to be able to be here and share a little bit about the work that we have done in several KT projects. I'm coming to you from Washington State, so I'm here in the USA, but Becky is coming to you from South Africa. So she's up quite late in her day to make this presentation, and hopefully all the internet connections work as we proceed. So today we're talking about practical KT, and really the purpose of this presentation is to focus on KT strategies that are practical and rigorous and kind of address a problem that we've experienced as we have worked through several programs. And that is that although knowledge translation aims to reduce the knowledge to practice gap, many of the most rigorous knowledge translation strategies are not always practical in kind of day-to-day use or to answer the types of questions that consumers most frequently have. And so in this presentation, we'll address two practical KT strategies that we've developed through a number of our NIDLR-funded projects that involved KT. The outline for this presentation is as follows. We'll start with me talking about why we need practical KT strategies, and then Becky will take over and she will describe the two strategies that we want to discuss today. Strategy one is focusing on consumers as experts, and strategy two is a national review process that we've developed. And then Becky will finish up talking about benefits and looking forward, and then we'll move into a question and answer period. So why do we need practical KT strategies? You all are probably familiar with this pyramid of evidence-based practice. So it starts at the bottom with editorials, expert opinion, and it climbs up through case series and case reports, up to case control, cohort studies, RCTs, and I realize I am not moving my slides, so there you go, RCTs, and finally up to systematic reviews. So there are a number of these models out there, and they all look a little bit different based on the research methodologies that are included. But the general idea is that there's a hierarchy of research methodologies. So higher quality evidence is developed by those methodologies nearer to the top of the pyramid. And the methodologies at the bottom of the pyramid have more significant threats to the validity of the findings. In much of the work that's been conducted related to evidence-based approaches, the emphasis has been placed at the top of that hierarchy. So how can we conduct better systematic reviews? How do we evaluate the quality of RCTs and so forth? And so until recently, there's been relatively less emphasis on the synthesis and use of lower levels of evidence. So why is this a problem? There are a couple reasons. First, if we focus just on systematic reviews, we know that systematic reviews are really expensive. So they cost between, well, it's hard to say, but $20,000 to $100,000 to conduct, depending on the topic and the scope. They can take several months of full-time effort, although they usually take longer because researchers who are working on them within the context of other projects. They can't be conducted, you can't even conduct a systematic review until you have enough high-quality research that's been conducted in the field to support a review. And so because of that, systematic reviews come a long time after the issue or the question has been raised as a concern. And there's usually quite a gap between the asking of a question and the ability to have an evidence-based answer using a systematic review. Now, there are a number of different approaches to systematic reviews, and some types like metasynthesis or realist reviews can respond to broad questions and do use a variety of data sources. But the type that are most encouraged in the health sciences today are more narrowly focused in terms of questions and evidence that's included. So if you look at the Cochrane Review Library, for example, you find these kinds of questions. Is acupuncture effective in the prophylaxis of tension-type headache? Does vitamin C reduce the incidence and length of colds? Or I noticed one that was asking which fall prevention interventions are effective for older people living in the community. And those are all important questions, but they're quite narrow. People are often more interested in broader questions. So what do I need to do to prevent and treat my tension headaches? How do I avoid catching a cold? And what should I do once I catch one? Or, what should I do to make sure my adult parents don't fall and injure themselves? So those are the types of practical, pragmatic questions that are not answered easily, if at all, by a single systematic review. They really require a broader application of evidence. Another reason we need practical strategies in terms of our thinking about systematic reviews is that we simply don't have research evidence on every question we need to answer. So you all know that research projects take a long time to plan, to propose, to seek funding, to implement, and then to report and to get into publication. So it could take many years to complete a single study, but then a single study is not enough to write a systematic review. And if that study doesn't meet the inclusion criteria for a review, either because of the sample or the research design, then it won't be included. And reviews are often started only to find that there's not sufficient research evidence to complete them, and these are called empty reviews. Again, if you look at Cochrane, at the Cochrane Database of Systematic Reviews, in 2012 it contained a total of 4,320 systematic reviews, and of those, 376, or around 9%, were empty reviews. Now, empty reviews are a problem in that they don't provide any guidance. But even beyond empty reviews, there are a lot of reviews in which the authors find that although there are adequate number of studies to conduct the review, that they're all of lower methodological quality or they have conflicting evidence, so the question still can't be answered. And in those situations, we're still left with the question, right? The question doesn't go away even if we can't answer it using systematic review methodology. So we need to figure out practical ways to help consumers. Luckily, there is ongoing work to develop new methods for evaluating types of evidence that don't fit within traditional systematic review methodologies. These include things like the use of scoping reviews to look at the broader landscape of research evidence before starting a systematic review. This can lead towards decisions to either not conduct the review or to use a different review methodology. Qualitative methodologies or metasyntheses that allow for a review of qualitative research, and then mixed methods and realist reviews supporting the inclusion of both qualitative and quantitative evidence. But these are not universally accepted within the field, and they're still in development. So again, until we reach consensus on these approaches, we still need practical strategies. A lot of the difficulty in conducting systematic reviews rests on their reliance on the use of only certain types of evidence, and in particular, randomized controlled trials, or RCTs. And these research designs require that participants in the study be randomly allocated to one or more treatment or control groups. And they're challenging to conduct in some populations, including many rehab populations, because we often have a small sample size that's available to us. Often the treatment that is most appropriate is an individualized and customized treatment, individualized to the specific individual, rather than something that's more unidimensional, like a certain amount of vitamin C given consistently. It's also true that allocation decisions that require concealment or blinding are often not possible in rehabilitation populations. It's hard to blind somebody to the type of intervention that they're administering. And then there are just ethical concerns regarding the use of control groups. So, can you withhold a promising intervention from someone when it's likely to be better than an alternative? And, it's a little bit different from a pharmaceutical trial where you may really not know whether compound A will work better than compound B. We often are making theory-based interventions that we believe will result in better better outcome for people. And so, so this is part of the challenge in conducting systematic reviews. So finally, regardless of the evidence, what evidence exists now or may exist in the future, people out in the real world have to make decisions today, and we can't ignore that need. We have to offer the best available evidence that we have available now. And that may mean simply expert opinion. It's not ideal, but it is realistic, it is practical, and we need ways of capturing best available evidence and conveying it to consumers. So best available evidence just really means the best available evidence at the time when one is engaging in knowledge translation practices. And it doesn't mean we don't strive for better evidence, but that we do bring together the best that we have and provide it to consumers, and we have a mechanism for updating it as more information comes along. So today we're going to present 2 practical KT strategies, and we're going to do that within the context of our work managing a couple NIDLR-supported KT centers, as well as other projects that had significant KT emphases. And I just wanted to sort of give you a sense for how we have conceptualized our work, because our strategies fit within this broader conceptualization. So we think of our KT centers as KT platforms. That is, as national or regional level institutions that foster linkages and exchange across a system and can be the institutional equivalent of a knowledge broker. And as many as you know, a knowledge broker is an organization or a person that acts as a connector between the world of research evidence and the world of practice. And in making that connection, brokers provide information in both directions, right? So information to researchers about practice-based questions that need to be answered, and information to consumers, professionals, policymakers about best available evidence. So they become knowledge transfer and exchange points. And to do this, they need to understand not only what evidence exists to answer questions, but how to best provide that information in understandable ways to the people who need it. So KT platforms can function in a variety of ways. They can help to address the needs of the policy process by connecting that process to research tools. They can support public dialogue that will help instill an understanding of research processes and evidence from the literature. And broadly, they can create a knowledge base that's user-friendly, that's easily accessible. They can organize and schedule dialogues and meetings for exchanges to occur between evidence developers and evidence users, if you will, and provide courses and other training interventions that build and strengthen the knowledge and skill base or capacity of the stakeholders in the system. Let's see. And so the strategies that we'll provide really are strategies that we've developed to help us to do that, to engage in that task, to strengthen capacity, to provide information, and to give the best available evidence that we have at the time. So I'm going to turn this over to Becky now, who's really going to discuss the development and implementation of those strategies.
Hello, everyone. Can you hear me okay?
Yes, you're fine. Thank you for asking.
Okay, great. I'm really going to describe how we implemented these practical KT strategies. I was the main manager for both the knowledge translation centers for the KT process, and also have been working on the rehabilitation research and training centers on multiple sclerosis and aging around consumer product development. So our expertise really evolved through these projects. We had the Model Systems Knowledge Translation Center that many of you, I'm sure, are familiar with, are comprised of 34 model systems nationwide, the TBI, SCI, and Burn model systems. 2 rehabilitation research and training center projects, one focused on multiple sclerosis and the other one on aging. And then we have our ADA Knowledge Translation Center that involves 10 regional ADA centers. So the 2 strategies I'm going to be describing, one is really focused more on the health information that we developed through the first three projects, the Model Systems, Knowledge Translation Center, and the two RTCs. And the second strategy is focused on ADA information that we developed through the ADA Knowledge Translation Center. So how we actually developed this project was because our original approach wasn't working. So when we started with MAKTC in 2006, we thought we were going to conduct these systematic reviews, and then out of the systematic reviews, we're going to develop these very consumer-ready materials that would be kind of like plain language summaries of the systematic review findings. Once we started the systematic review process, we realized, as for many of the reasons that Mark just described, that it just wasn't practical, that it was going to take way too long for us to get to the findings of the systematic review, and the questions themselves that the systematic reviews were addressing were way too narrow for the consumer products that we needed to develop. So we needed, for example, a product on how do people address sleep problems who have traumatic brain injuries. And the systematic reviews were not designed to address a broad question like that was consumer focused. So we instead rerouted our strategy and developed a different process for developing evidence-based and evidence-informed consumer materials. So the general process that we use for both of the strategies was a 5-step process. So we had topic selection, content development, readability or KT review, an expert review, and then the final step being the approval. Most of these projects were national projects, so approval by the national directors, and then dissemination through various networks. For each of the two strategies, one that was more focused on health information, the second one focused on the ADA, the Americans with Disabilities Act information, there were differences in each of these steps. So for the topic selection, there were different structures in place to identify what were the high priority topics that consumers within the model systems wanted to know about. There was consumer advisory groups that would inform those priority topics. Within the ADA project, we had a KT committee structure that was really the main body of consensus that would identify which ADA topics that we should develop consumer information on. For the content development, lead authors for health products were often clinicians and researchers that we would provide general writing guidelines to and a format for how to develop the consumer information. And within the ADA network, the content primarily came from one of the 10 regional centers. So one of the regional centers would draft the content, and that the KT committee would decide that this is appropriate to be a national product, and then it would go through a national review process. For both strategies, we had a very comprehensive readability review, and our expertise in doing readability reviews really developed over time. It went beyond the basic plain language, I guess, criteria. So things like, making sure you use simple terminology and short sentences, using bullets instead of long paragraphs, and really expanded into tone and language use and writing style, and it continually evolved as we learned from our consumers and experts in the process what people actually need and want, and what information is going to be they're going to be most receptive to. The fourth step, the expert review, for the health information, it was primarily through consumers who had the specific health condition or concern. And in the ADA project, the experts were really frontline ADA experts. And then the fifth step was the review, the approval process and dissemination. So the first strategy that we called consumers as experts, we didn't actually initially think that the consumers were going to be the primary experts when we started the process. We had the lead authors develop the content and then conducted the readability review to make sure the content was user-friendly and readable, and initially saw that step of having the consumer review is really ensuring that the information was accurate, that it was complete, that it was clear, and possibly making some final revisions. What we found through the consumers as expert approach was that we actually would end up making pretty substantial revisions based on consumer feedback. And I'll talk a little bit more about that when I get into strategy one. And likewise with the national review process, each step from identifying the topic to going through the KT committee selecting experts to review the content and the readability review, from beginning to end, we would end up with a very different product than we started with. So for strategy one, consumers as experts, we ended up developing over 60 evidence-based consumer fact sheets on high priority topics for those 3 projects that I had mentioned earlier in the presentation. I'm just going to provide on a couple slides some examples of what these products were like. So some of them were in series, so they would be a multi-part fact sheet series on understanding TBI that would have various components to it. Sometimes it was just a couple pages on one specific topic, like driving after TBI, so they would be a standalone fact sheet. As you can see here on this slide, this is just a sample of I believe we developed maybe over 20 for the TBI model system. We also really tried to develop these products so that they were very concise, so that we aimed for less than 4 pages. That didn't always happen, but our goal was to provide an overview of the most important information on this topic in the most concise way possible. And we learned that through the consumer review process, knowing that people are not going to spend a lot of time if it looks too intimidating in length. So these are just more examples from the SCI model systems. We developed a multi-part fact sheet series on skincare, pain after SCI, a series on wheelchair prescriptions, etc. We also had graphics developed specifically for the fact sheets when it was appropriate, and those would be reviewed by both clinicians and by consumers to make sure they were accurate and communicated what needed to be communicated. And we have some more examples here from the burn model systems. And you notice it wasn't always health topics either. We even got into returning to work, social skills, and burn injury. It was predominantly health related, but there was also other high priority topics that would surface. So the process that we went through with consumers as experts, the 5-step process that I described earlier on, the most important step in that process was really talking with consumers. So we would conduct interviews, semi-structured interviews with consumers who were from the specific population. So for a person with SCI, TBI, or burn, we tried to get a diversity of perspectives and also different levels of health information I guess, savviness, some people that weren't online at all, that we would actually mail hard copies of the fact sheet to them to make sure that it also was reaching people that aren't online. So during the interview process, we asked a series of questions to really understand what was most useful, least useful, what was missing, what was not clear, was there anything that wasn't true to their experience. And through these interviews, we, as I said earlier, we ended up making some pretty substantial changes to the content. And these changes, so we'd synthesize the interview feedback, we'd provide that back to the lead author, and then the lead author would decide on which feedback to incorporate into the revisions, because obviously we couldn't incorporate everything. Either it didn't have any evidence to support it, or it was possible that it was just beyond the length that we were trying to fit within. So some of the ways that consumers' expertise really changed the content was they actually helped reorganize the content. At times they identified things that we should emphasize maybe at the beginning or with bold print that they thought that was really important, that should stand out. They also identified what was missing. So I think we've often found through this process that you provide guidance on what you should do, talk to your health practitioner about these things, but you don't provide that next step. So if you recommend go seek out this type of therapist, the consumer would tell you, well, where do I even find that type of therapist? So then based on that feedback, we would add additional resources to the fact sheet to make sure there was those steps in place. We also found new evidence would emerge. So there would actually be new information that would come from consumers that would then go back to the lead author, that the lead author would validate as this is based on expert opinion. Perhaps there wasn't any systematic review on it, but expert opinion that they agreed. And I have an example here on the slide. I think this was from the people with multiple sclerosis, that they found that eating small, it was on fatigue, multiple sclerosis and dealing with fatigue, and consumers were saying that eating small meals throughout the day really helped with energy level, which may sound small, but there was a number of consumers that agreed with that. And then we had our lead author that also thought that was important to include, so that was included in the fact sheet. There was also times where we found that information in the fact sheet was not consistent with what consumers were experiencing. And I listed the example there of people managing MS also have found that taking short naps can help during the day. When we had a fact sheet on sleep in MS, and we recommended that to not nap during the day. So we ended up changing that information on the fact sheet because it was not consistent with what consumers were experiencing. Other benefits of having consumers as experts was consumers would actually learn things through being involved in the interviews. They would also inform us of different places where we can disseminate this type of information, such as support groups. They also would identify new important topics. I think this initially kind of came up just as part of conversation. Have you guys worked on any fact sheets on this new issue? But then we actually included that question in our interview guide eventually, because we realized that was a really important opportunity to start getting a list generated of new topics that consumers are interested in, and then that list would go back to the consumer advisory panel to prioritize for the next round of fact sheet development. Consumers also really appreciated being involved in something that was very concrete, that we could send them the fact sheet when it was finalized, and they could see how their input was incorporated or not incorporated into it. And a lot of the consumers that were involved in the model systems projects had also either signed up on a newsletter to participate in research or had been involved in some research studies before. So they weren't used to the experience of being involved in something so tangible, that they would participate in a, they'd fill out a survey, but they would rarely be sent the peer-reviewed publication that came out of it. There wasn't that direct feedback. So there was a strong interest in being involved in something that was so concrete, and that the consumers who really did value the end product would share the fact sheet with their network and with their health professionals. There was a lot of lessons learned through this process, but one I just wanted to highlight was that we realized over time that we started out with a general structure of how we would develop the health fact sheets, and they would generally start with describing the problem. What is the problem we're addressing? What's the extent of the issue? What are the symptoms people experience? What are the causes of these, the condition or symptoms? And then we would go into solutions. What can you do? But when we started the process, we would spend a lot more energy describing the problem, and or more real estate on the fact sheet was devoted to describing the problem and explaining it and what are the causes, and less space was devoted to the solutions of what can I do? I have problem X. And we learned pretty quickly that that was not the right approach, that consumers really, they want to understand what are the problems coming from, but the real emphasis of these types of information resources should be on solutions, and not just solutions. I would say maybe a hierarchy of solutions, kind of what can I do on my own, what lifestyle changes I can make, and then next would be what treatments can I seek if it's therapies or medication. But that was really important, and we actually built that into our guidelines for the lead authors that would develop the draft content, to make sure that there was as much emphasis on the solutions as in describing the problems. So now I'm going to move on to the second strategy. So this is a very different animal, I guess I would say. This is, moving away from medical health information, working with model systems that are doing a lot of clinical practice and research, into a totally different realm of the Americans with Disabilities Act laws, regulations, building codes, guidelines. It's very technical, legal, and very broad arena of topic areas that are addressed by the ADA. And also this national network was a very different structure. The 10 regional centers that provide technical assistance and training and outreach and developed information resources on the ADA are really all on the front line of addressing ADA issues day to day, from a wide variety of audiences with all different levels of background, people that are not familiar with the ADA at all to people that have a lot of knowledge that are ADA coordinators and needing something very specific. So this was a very different, obviously, topic area, and a very different structure and type of network. So we couldn't just take what we had developed in this previous grant and bring it into this project. So we really did try and figure out, as Mark described earlier, like how could we facilitate bringing the best evidence to the surface within this existing structure. So maybe I should back up a little too, is, these national fact sheets that we developed with the ADA National Network needed to be pretty broad and an overview of these ADA topics, because a lot of what the regional centers do is provide regionally specific guidance and information, and a lot of their materials they develop are also targeted towards that region or that state, and maybe because of the legal or regulatory differences within those regions, but also the needs are different within the regions. What are the priorities within the region? So it was a really a process to figure out what structures we needed in place to come up with this national consensus of what are the most important topics that the national network should develop and disseminate nationally around the ADA. So for this, the national review process, we've so far developed about 40 national products, and they really have ranged from a couple page fact sheet on the topic to a 100-plus page booklet on ADA and disability law, for example. And similar to this first strategy, we really did focus on creating plain language, consumer-friendly information. So this was we really put a lot of effort into trying to make this as accessible and usable for a wide variety of audiences as possible, and which is tricky with medical information, but it's also very tricky with legal information. So these are some of the examples of the products we developed through the ADA National Network process. And so there's sources of employment and disability data, accessible parking, adjusting doors for access, and that fact sheet actually shows you, how to adjust a door within any kind of facility, accessible health care. I put one example here of there was a new law about the Vietnam-era Veterans Readjustment Assistance Act, and that was something that we found, which was quite different, I guess, in the ADA project, is when you're identifying the high priority topics, it's not always what's most prevalent. It's not what are the information that the most people need, or the greatest need in terms of numbers or in terms of gaps, where are the major gaps. It was sometimes because it was just really timely that there was a new regulation that came out, and it was a high priority because this is a change, and it may only influence a smaller group than some of these broader topics, but it was a higher priority because this is completely new information that needs to get out there. There was also sometimes there was no gap in information. There was an overabundance of information, like on service animals, but there was so much misinformation out there that became a higher priority to try and develop some really concise, accurate, user-friendly materials on service animals, because it's a very complex area with too much information. So we kind of learned through this process that prioritizing wasn't just about prevalence or just about gaps. So in this second strategy, as I said earlier, the KT committee was the main structure that would really nominate the topics, would select the experts that would do the reviewing of the product, and then also provide their own review and guidance or feedback on the product, so that they were really the key mechanism to developing the national products. Most of the content was originally authored by a regional center, and often that was because of a regional need. So there was something that the one we're working on right now, one of the regions was finding there's a lot of requests for information on post-secondary schools and the ADA. So that KT committee member would bring that to the national committee and say, does this make sense to be a national product? Or is this really something that we're just dealing with in our region? And if the KT committee says, yes, this makes sense, this is something we're dealing with too, that we agree that this should be prioritized as a national product, then we begin the process. And part of that process is discussing within the KT committee, what are the aims of this product, who needs it, who's the audience, and then starting to generate some feedback from members of the committee of, where are there some existing evidence or resources we can tap into. For example, maybe somebody had seen a great webinar recently on this and knows who the presenter was on it, so we could contact them for feedback. So then once we have, like this example of the post-secondary school fact sheet, once we have that selected as this is a high priority topic, we're going to move forward through the national review process. The KT committee identifies an expert reviewer that will review the product for accuracy and completeness. And there wasn't always, well, I'll talk about that a little later, but it wasn't always easy to get expert reviewers. We opened it to, initially we had it of individuals within the network, but then we expanded that to include individuals also outside the network. So maybe they weren't staff within any of the regional centers, but they were seen as the go-to person for the members of the national network on a specific topic area. So we would also use people outside the network to do the expert review for accuracy and relevance. So after that was completed, our center would conduct the readability review, which was really about making sure the language is concise, the terminology is simple and appropriate, the formatting is easy to read, it's has really concise, clear headers. I'm not the readability expert. We have somebody else doing that, but there's a whole list of criteria she goes through to make sure we're addressing the readability issues. And then it goes to the regional directors. All 10 regions review the final product and make sure that it's, and sometimes we've had it kicked back at that point, even though we've gone through the whole process, but we get to that point and a director or a couple directors say, no, this is missing this, or this isn't quite right, or the tone needs to change, and then we'll pull it back and do more editing. And then when it's finalized and it's approved by the directors, then our group does the formatting and branding and disseminates through multiple formats. Oh, I'm realizing I'm getting questions.
Yes, you are. Did you want to take those as they came in, or do you want to hold and take them at the end?
Yeah, actually 2 of them I'll address at the end anyways, but one of them is a yes. You can access all these products and we can provide those links. So we could do that at the end as well. Okay. Actually, I probably need to speed up a little. Looks like I have 15 minutes left. So a couple ways that this review process had changed the content, and again, I'm talking about strategy 2. I hope you're all not getting lost between strategy 1 and strategy 2. This is a lot to fit into one presentation. Similar to the first one, the tone really does matter. So we actually had developed a fact sheet on what services the national network doesn't provide, because it came out of a need that there's a perception that the national network does some advocacy or provides legal guidance and some things that they don't do, and so they wanted to create a really nice, concise fact sheet that really described what they do and what they don't do, but the tone was a little not so welcoming because it had a lot of we don't do this and we don't do that. So, so we went back to the drawing board and framed that in a more positive way. We also, again, identify what is missing, identify what's the appropriate terminology we should be using, what's not accurate, and that, it could be because there was a change in a regulation where we've had a couple of times where we've updated some older public accommodation information where the spacing and the dimensions on certain pathways had been changed in the most recent update. So we would catch those through this review process. And then the readability review that our group conducts, I can't take credit for any of it because we really have one person on our staff who this is her specialty. And even though she's familiar with the content area because she's been doing this for a while, she's always able to see it as kind of with fresh eyes to not make any assumptions. It's like anytime you're in a field too long, you see terms and they make sense to you instantly, but they don't make sense to a lot of people. So, so being able to know what is not clear, to know what needs more detail, what needs both kind of the legal terminology, but also the plain language terminology is really important to making these accessible to a wide audience. Some other components of our plain language review, I guess I've already stated this somewhat, the writing style, the formatting, the organization of information is really important too, just for the flow of information, but also the, if the beginning of a fact sheet doesn't draw people in, if it doesn't say, this is what this is about, this is what it's going to cover, if the headers aren't clear, people aren't going to get that far with it. So really making sure that it's well organized is important. Some lessons learned from strategy 2, although I think this could apply to both strategies. We really had to continue to revise our procedures to work with the national network structures. And this is, I think this is probably true in any national system. People are working on their regional issues and they're working on their specific regional projects. So you can't get everybody's attention all the time to work on these national projects. And so really trying to think through what procedures make the most sense and that are the most practical. So for example, I don't know if you saw on a slide, a couple slides back, we started with making sure that all 10 directors of the national network would approve a national fact sheet. So, if it meant we were going to have to wait around for a while to get that 10th person, we would do it. But then it just would delay things too long to need all of the 10 directors to review and approve every fact sheet. So we changed that to 7 out of 10. The KT committee agreed that that was sufficient to say that this is a national product. And it sounds simple, but those important tweaks actually make this machinery work. Because otherwise you get a lot of stuff that just gets stuck and what we would call the kind of procedural quicksand, or having too many authors. If we started out in too many expert reviewers, too many authors, you just end up with a quagmire of debates about what should be included and what's most important. And so really making sure we had a lead author and that person was vetted to say this is the person who really should be the expert on this product, and they would make the final decisions. We also have that with the ADA Center, that it's really the originating center of the product that makes the final decision. So we give them, we can give them a lot of readability edits, that may really restructure and reword what has been written. It's all in track changes and in comments, and they decide what they're going to incorporate and what they're not going to incorporate. And it can't be a long, painful process, because ultimately, these need to see the light of day within a reasonable amount of time, or we could go back to doing the original process of a systematic review. So some lessons learned from these practical KT strategies. So the most important one is that people on the front line of service delivery or practice, the consumers, should always be on the front line of evidence creation, and that we should really work hard to create those mechanisms and those processes to make that happen. We also learned that tone and language really matter a lot, and that's both in providing truthful information, not too overly, I guess it's more with the health information, not too overly positive. Like, be realistic about what these conditions are, what people experience, what the real solutions are. That juggling that the medical and legal terms with plain language is a pretty complex process, and I think what we've learned at this point is it's always important to include both. That it's important for people to have the medical terminology for when they're talking with their health professionals, and for people to have the legal terminology, if they're going to court or whatever with their ADA issue, but to also include the plain language of that. What is undue burden? That's not something people use, so we need to describe more what that means. And also to be really simple and concise, because we want these to be understandable by a broad audience, but not condescending. So that's just another balancing act. And that maybe the most the most important lessons about procedures is that there's always exceptions. So we've created, I don't know how many standard operating procedures now that have been refined over time, but then inevitably there'll be a point where you'll get to the very end where you've gone through all the steps and you think this is ready to roll, and you discover that something's not quite right with it for a really important reason, and it needs to go back to the drawing board. So there's always exceptions to the process. Some of the challenges we've experienced are around the quality of expert feedback, and that's also in the level of detail, because sometimes we get our expert reviewers that will rewrite an entire section, and it's great, and sometimes we'll get this is missing, but we need to give that back to the original authors and figure out how to fill in that gap. Sometimes there's disagreements about priorities. I guess that's both in terms of what topics should be next and also in what content is most relevant. The responsiveness, which I've already touched on a bit, is pretty important, because this information needs to get out there. And like I said, it's really hard to get everybody engaged and paying attention all the time. This isn't their job. This is part of many things that they're working on. So I think that's why it's really important to have lots of checkpoints along the way. Also, the evidence is always changing. So it could be that there's an important new case, that was worked out in the Supreme Court that really changes the way ADA regulation is in practice. It could be new health information that's coming online. So it's really important to continually review and update the products we're developing. And we have an annual review process that we've put in place with with both of our projects. But just seeing information that we've developed quite a while ago that hasn't been updated, it's problematic. I think there needs to be emphasis on that. Even if it's just reviewing just to ensure that there hasn't been anything major that's changed, it's worth that process. So our KT perspective, I think we're getting into the wrap-up now, is that what we've learned is that consumers and experts, I guess we'll say practitioner experts within the ADA, are really looking forward. They're looking at, what's going to make my life better now? What are the most critical information needs in order for me or for, my consumers that I'm working with to make the best decision or to take action. So that's really their orientation, and they're addressing these issues day to day. How we started this presentation is looking back at kind of the systematic review process, and really from a researcher's perspective, it's really more looking backward, and it's what has worked and what does the evidence tell us. And really, the more you're able to look back in terms of studies that have been completed, years ago, that you can synthesize all the findings, the better your evidence is. But again, that's not always practical to dealing with the issues that are constantly evolving in front of us, and the information needs that are evolving in front of us. So looking ahead, and this gets to one of the questions. I don't know if this is not really easy to see, but this is one of the many knowledge translation frameworks. I guess the main points here I wanted to make are that both of our strategies, Strategy 1 and Strategy 2, really focus on the left side of this diagram. So in creating the evidence, adapting it for various audiences, I can't even read it, so small. but what we're now working on more is on the right side of the diagram, which is evaluating the outcomes, monitoring the usage, and then looking at sustained knowledge use. And there's some very simple ways to do that, like tracking usage. So, all our products are online, and you can track the Google Analytics, the downloads. You could also try and do some hunting and searching and figure out which organizations are adopting those products external to your network. So that at least starts to get at usage. Where is it being used? Who's using it? How much is it being used? Evaluating outcomes of how these fact sheets are changing people's understanding, their knowledge, their behavior is a bit more complex. And we know anecdotally that there's, just from what we hear, especially through doing the consumer interviews, that people are using it and using it to make decisions, and maybe bringing it to their health professional to talk about some certain treatments that weren't on their radar before. But this is a very difficult thing to try and rigorously, and maybe it's not practical either, to rigorously quantify how these fact sheets are changing people's lives. And it's just one piece of the puzzle, that there's lots of other sources of information that people draw upon to make decisions. So it's really hard to say what is the impact of these particular products. So these final slides are really just examples of how some of our information has been adopted and adapted. This is an example of a graphic novel that's been developed out of the traumatic brain injury and sleep fact sheet, and there's been a number of other ones that they've also developed. But a very creative and geared towards a younger audience, which is more the target audience around people who suffer from TBI. I need to wrap this up. Oh, that's the end. Okay. So, moving into resources. And we have a lot of our websites there under resources that have the products. And I guess I'll just wrap up there.